Oral medicine non-infective stomatitis and infective stomatitis. Dr. Mohammed Hossein BDS, M.Sc, PhD, Oral Medicine. Erythema multiforme, EM, is an acute, self-limited, inflammatory mucocutaneous disease that manifests on the skin and often oral mucosa, although other mucosal surfaces, such as the genitalia, may also be involved. It represents a hypersensitivity reaction to infectious agents, majority of cases, or medications. In general, EM is classified as EM minor if there is less than 10% of skin involvement and there is minimal to no mucous membrane involvement, whereas EM major has more extensive but still characteristic skin involvement, with the oral mucosa and other mucous membranes affected. However, there is likely a subset of EM that affects the oral mucosa only without skin involvement. Historically, fulminant forms of EM were labeled Stevens-Johnson syndrome, SJS, and toxic epidermal acrolysis, TEN, Lyell disease. However, more recent data suggest that EM is etiopathogenetically distinct from those two latter conditions. The etiology is not clear, and though the disease may be reaction to a variety of causes, no convincing mechanism has been proposed. Infections, particularly herpetic, can be triggering factors. Drugs, particularly sulfonamides, NSAIDs and barbiturates, have also been implicated, but a positive drug history is also rare. EM generally affects those between ages 20 and 40 years, with 20% occurring in children. Patients with recurrent EM have an average of 6 episodes a year, range 2 to 24, with a mean duration of 9.5 years. Remission occurred in 20% of cases. There may be a prodrome of fever, malaise, headache, sore throat, rhinorrhea, and cough. These symptoms suggest a viral, especially respiratory tract infection, and this is not surprising since infectious agents are known to trigger EM. Skin lesions appear rapidly over a few days and begin as red macules that become papular, starting primarily in the hands and moving centripetally toward the trunk in a symmetric distribution. The most common sites of involvement are the upper extremities, face, and neck. The skin lesions may take several forms, hence the term multiforme. The classic skin lesion consists of a central blister or necrosis with concentric rings of variable color around it called typical target or iris lesion that is pathognomonic of EM. Variants are called atypical target lesions. The oral findings in EM range from mild erythema and erosion to large painful ulcerations. When severe, ulcers may be large and confluent, causing difficulty in eating, drinking, and swallowing. And patients with severe EM may drool blood-tinged saliva. Extensive lip involvement with inflammation, ulceration, and crusting is common. Mild oral EM can be managed with systemic or topical analgesics for pain and supportive care since the disease is self-limiting and resolves within a few weeks. Patients should be warned of the possibility of recurrences, but that the disease usually runs a limited course. There is no specific treatment. Systemic corticosteroids may give symptomatic relief in severe cases. Antibiotics are usually also given in severe cases with the idea of preventing secondary infection. In some cases, acyclovir is effective. Other treatment modalities include dapsone, hydroxychloroquine, azathioprine, colchicines, methotrexate, and intravenous immunoglobulin. Studies done within the last 10 to 15 years now support the concept that Stevens-Johnson syndrome, SJS, is a less severe variant of toxic epidermal acrolysis, TEN, and separate clinically and etiopathogenetically from EM. Although all three are hypersensitivity reactions and give rise to oral bully, erosions, ulcers, and crusted lips, the skin lesions of SJS and TEN are different from EM. They are more severe and tend to arise on the chest rather than the extremities on erythematous and purpuric macules. These lesions are called atypical targets. The mucosal surfaces of the eye, genitalia, and mouth are almost always severely affected by SJS/TEN, always with skin involvement. The typical oral manifestation is extensive oral ulceration, with hemorrhagic crusts on the vermilion and oral and other mucosal surfaces. The lesions may extend to the pharynx, larynx, and esophagus. The ocular lesions consist of conjunctivitis and uveitis. The genital lesions are vulvovaginitis and scrotal erosions. The skin manifestations may vary from very light to severe. The diagnosis is mainly made on the basis of the clinical presentation. Because of the severity of this condition, treatment is generally with intensive supportive care because of loss of skin barrier, intravenous immunoglobulin, systemic steroids, cyclosporin, plasmapheresis, cyclophosphamide, and TNF-alpha inhibitor. Infectious diseases of oral mucosa. Primary infection is caused by herpes simplex virus, usually type I, which in the non-immune person, not exposed to the virus previously, can cause an acute vesiculating stomatitis. However, most primary infections are subclinical. Therefore, recurrent, reactivation infections usually take the form of herpes labialis, cold sores or fever blisters. 1. Primary herpetic gingivitis. The two major types, HSV1 and 2, can be distinguished serologically. Classically, HSV1 causes a majority of cases of oral and pharyngeal infection, meningoencephalitis, and dermatitis above the waist. HSV2 is implicated in most genital infections. Although this distinction applies to a majority of cases, changing sexual habits are making that distinction less important. Both types can cause primary or recurrent infection of either the oral or the genital area, and both may cause recurrent disease at either site. The early lesions are vesicles which can affect any part of the oral mucosa. The hard palate and dorsum of the tongue are favored sites. The vesicles are dome-shaped and usually 2 to 3 mm in diameter. Rupture of vesicles leaves circular, sharply defined, shallow ulcers with yellowish or grayish floors and red margins. The ulcers are painful and may interfere with eating. The gingival margins are frequently swollen and red, particularly in children, and the regional lymph nodes are enlarged and tender. There is often fever and systemic upset, sometimes severe, particularly in adults. Oral lesions usually resolve within a week to 10 days, but malaise can persist so long that an adult may not recover fully for several weeks. The clinical picture is usually distinctive. A smear showing virus damaged cells is additional diagnostic evidence. A rising titer of antibodies reaching a peak after 2 to 3 weeks provides absolute but retrospective confirmation of the diagnosis. Acyclovir, 200 to 400 mg, 5 times daily, for 7 days, is a potent antiherpetic drug and is life-saving for potentially lethal herpetic encephalitis or disseminated infection. Acyclovir suspension used as a rinse and then swallowed should accelerate healing of severe herpetic stomatitis if used sufficiently early. Bed rest, fluids and soft diet may sometimes be required. Local anesthetic before meal helped children to eat the foods. Inflammatory drug needed to control the fever and pain and reduce the exacerbations of inflammation of this disease. Metronidazole helped to control the secondary infections such as the gingivitis. Systemic nonsteroidal anti-inflammatory drug needed to control the fever and pain and reduce the exacerbations of inflammation of this disease. After the primary infection, the latent virus can be reactivated in 20 to 30% of patients to cause cold sores, fever blisters. Triggering factors include the common cold and other febrile infections, exposure to strong sunshine, menstruation or, occasionally, emotional upsets or local irritation, such as dental treatment. Neutralizing antibodies produced in response to the primary infection are not protective. Clinically, changes follow a consistent course with prodromal paresthesia or burning sensations, then erythema at the site of attack. Vesicles form after an hour or two, usually in clusters, along the mucocutaneous junction of the lips, but can extend onto the adjacent skin. The vesicles enlarge, coalesce and weep exudates. After 2 or 3 days they rupture and crust over, but new vesicles frequently appear for a day or two only to scab over and finally heal, usually without scarring. The whole cycle may take up to 10 days. Secondary bacterial infection may induce an impetiginous lesion which sometimes leaves scars. In view of the rapidity of the viral damage to the tissues, treatment must start as soon as the premonitory sensations are felt. Acyclovir cream is available without prescription and may be effective if applied at this time. However, pencyclovir applied 2 hourly is more effective. Both primary and secondary herpetic infections are contagious and cause herpetic cross-infections called herpetic whitlow, which is a recognized uncommon hazard to dental surgeons and their assistants. Herpetic whitlows, in turn, can affect patients and have led to outbreaks of infection in hospitals and among patients in dental clinics. Now that gloves are universally worn when giving dental treatment, such cross-infections should no longer happen. In immunodeficient patients, such infections can be dangerous, but acyclovir has dramatically improved the prognosis in such cases and may be given on suspicion. Mothers applied antiherpetic drugs to children's lesions should wear gloves. Coxsackie are ribonucleic acid, RNA, enteroviruses and are named for the town in Upper New York State where they were first discovered. Coxsackie have been separated into 2 groups, A and B. There are 24 known types of Coxsackie group A and 6 types of Coxsackie group B. These viruses cause hepatitis, meningitis, myocarditis, pericarditis, and acute respiratory disease. 3 clinical types of infection of the oral region that have been described are usually caused by group A Coxsackie viruses: hop angina, hand, foot, and mouth disease, and acute lymphonodular Pharyngitis. Types of Coxsackie virus A have also been described as causing a rare mumps-like form of parotitis. Coxsackie virus A4 has been shown to cause a majority of cases of hypangina, but types A1 to A10 as well as types A16 to A22 have also been implicated. Because many antigenic strains of Coxsackie virus exist, hypangina may be seen more than once in the same patient. Unlike herpes simplex infections, which occur at a constant rate, hypangina frequently occurs in epidemics that have their highest incidence from June to October. The majority of cases affect young children ages 3 through 10, but infection of adolescents and adults is not uncommon. After a 2 to 10-day incubation period, the infection begins with generalized symptoms of fever, chills, and anorexia. The fever and other symptoms are generally milder than those experienced with primary HSV infection. The patient complains of sore throat, dysphagia, and occasionally sore mouth. Lesions start as punctate macules, which quickly evolve into papules and vesicles, involving posterior pharynx, tonsils, facial pillars, and soft palate. Lesions are found less frequently on the buccal mucosa, tongue, and hard palate. Within 24 to 48 hours, the vesicles rupture, forming small 1 to 2 mm ulcers. The disease is usually mild and heals without treatment in 1 week. Hypangina may be clinically distinguished from primary HSV infection by several criteria. 1. Hypangina occurs in epidemics, HSV infections do not. 2. Hypangina tends to be milder than HSV infection. 3. Lesions of hypangina occur on the pharynx and posterior portions of the oral mucosa, whereas HSV primarily affects the anterior portion of the mouth. 4. Hypangina does not cause a generalized acute gingivitis like that associated with primary HSV infection. 5. Lesions of hypangina tend to be smaller than those of HSV. Hypangina is a self-limiting disease, and treatment is supportive, including proper hydration and topical anesthesia. This common, mild viral infection, which often causes minor epidemics among school children, is characterized by ulceration of the mouth and a vesicular rash on the extremities. Hand, foot, and mouth disease is usually caused by strains of Coxsackie A virus. It is highly infectious, frequently spreads through a classroom in schools, and may also infect a teacher or parent. The incubation period is probably between 3 to 10 days. The rash consists of vesicles, sometimes deep-seated, or occasionally bully, mainly seen around the base of fingers or toes, but any part of the limbs may be affected. The rash is often the main feature, and such patients are unlikely to be seen by dentists. In some outbreaks, either the mouth or the extremities alone may be affected. Lymphonodular pharyngitis is considered a variant of hypangina and is associated with CVA10. Patients report a sore throat, but rather than presenting with vesicles that break down to ulcers, patients develop diffuse small nodules in the oropharynx. CV infections are self-limiting, unless complications arise or the patient is immunocompromised, and management is directed toward control of fever and mouth pain, supportive care, and limiting contact with others to prevent spread of the infection. Effective antiviral agents for CV are not available. Oral medicine infective stomatitis 2 Dr. Mohammed Hossein BDS, M.Sc, PhD, oral medicine. Zoster, shingles, is characterized by pain, a vesicular rash, and stomatitis. The varicella zoster virus caused chickenpox in the non-immune persons, mainly children, while reactivation of the latent virus causes zoster, mainly in the elderly. Unlike herpes labialis, repeated recurrences of zoster are very rare. Occasionally, there is an underlying immunodeficiency. Herpes zoster is a hazard in organ transplant patients and can be an early complication of some tumors, particularly Hodgkin's disease, and increased in AIDS cases and potentially lethal. Herpes zoster usually affects adults of middle age or over, but occasionally attacks even children. The first signs are pain, irritation, and tenderness in the dermatome, skin, and mucosa, corresponding to the affected ganglion. Vesicles, often confluent, form on one side of the face and in the mouth up to the midline. The regional lymph nodes are enlarged and tender. Oral and facial lesions result from HZ of the trigeminal nerve, can be classified as involvement of first division. Ophthalmic is more common, and the lesions on the upper eyelid, forehead, and scalp, and may lead to corneal scarring and blindness. In the maxillary branch involvement, the lesions usually appear on the midface, upper lip, or even buccal gingiva. Involvement of third division, mandibular, leads to lesions on the lower face, lower lip, mandibular gingiva, and tongue. The acute phase usually lasts about a week. Pain continues until the lesions crust over and start to heal, but secondary infection may cause suppuration and scarring of the skin. Malaise and fever are usually associated. Herpes zoster is an uncommon cause of stomatitis, but readily recognizable. According to the severity of attack, oral acyclovir, 800 mg 5 times daily for 7 days, should be given at the earliest possible moment, together with analgesics. The addition of oral corticosteroids such as prednisolone may accelerate relief of pain and healing. In immunodeficient patients, intravenous acyclovir is required and may also be justified for the elderly in whom this infection is debilitating. Postherpetic neuralgia mainly affects the elderly and is difficult to relieve, and the pain is more variable in character and severity than trigeminal neuralgia. It is typically persistent, rather than paroxysmal. Postherpetic neuralgia is remarkably resistant to treatment. Nerve or root resection are ineffective and the response to drugs of any type, including carbamazepine, Tegretol, is poor. Application of transcutaneous electrical nerve stimulation, TENS, to the affected area by the patient himself for several times a day, is sometimes effective. By persistent stimulation the sensory pathways, so may prevent perception of pain centrally. Cytomegalovirus, CMV, is a member of the herpes virus group. Up to 80% of adults show serological evidence of CMV infection without clinical effects, but it is a common complication of immunodeficiency, particularly AIDS. In the latter it can be life-threatening. Oral ulcers in which CMV has been identified are sometimes clinically indistinguishable from recurrent aphthy, others have raised, minimally rolled borders. Generally, the ulcers are painful, large, shallow and single, rarely multiple, and affect either the masticatory or non-masticatory mucosa. Sometimes oral ulcers are associated with disseminated CMV infection. The virus present in oral lesions may merely be a passenger, but their causative role is suggested by reports of response to ganciclovir. Fevers which cause oral lesions are rarely seen in dentistry. Those which cause vesicular rashes, chickenpox, produce the same lesions in the mouth. In the prodromal stage of measles, Koplicks spots form on the buccal mucosa and the soft palate and are pathognomonic. Palatal petechiae or ulceration, involving the face especially, are seen in glandular fever and are accompanied by the characteristic, usually widespread lymphadenopathy. Kawasaki's disease is endemic in Japan but uncommon in British. It is frequently unrecognized and has caused significant mortality. Though its epidemiology suggests that it is an infection, this has not been established. Clinical features: children are affected and have persistent fever, oral mucositis, ocular and cutaneous lesions, and cervical lymphadenopathy. Oral lesions consist of widespread mucosal erythema with swelling of the lingual papillae, strawberry tongue. Bacterial infection. Bacterial infection. Oral tuberculosis is rare and a complication of pulmonary disease with infected sputum. Those with HIV infection are an important group of victims, but oral tuberculosis is occasionally seen in immune-competent persons who are usually elderly men with pulmonary infection that has progressed unrecognized or who have neglected treatment. The typical oral lesion is an ulcer on the mid-dorsum of the tongue, lips or other parts of the mouth are infrequently affected. The ulcer is typically angular, with overhanging edges and a pale floor, but can be ragged and irregular. It is painless in its early stages and regional lymph nodes are usually not affected. Lesions may occur the neck lymph nodes and it is termed scrofula. Management: diagnosis is confirmed by biopsy, chest radiography and a specimen of sputum. Mycobacterial infection is confirmed by culture or PCR, polymerase chain reaction. Oral lesions subside rapidly if vigorous multi-drug antibiotics is given for the pulmonary infection. No local treatment is needed. Congenital syphilis is syphilis present in uterus and at birth, and occurs when a child is born to a mother with secondary syphilis. Some infants with congenital syphilis have symptoms at birth, but most develop symptoms later. Untreated babies can have deformities, delays in development, or seizures along with many other problems such as rash, fever, hepatosplenomegaly, anemia, and jaundice. Sores on infected babies are infectious. Rarely, the symptoms of syphilis go unseen in infants so that they develop the symptoms of late-stage syphilis, including damage to their bones, teeth, eyes, ears, and brain. Blunted upper incisor teeth known as Hutchinson's teeth, mulberry molars, saddle nose, collapse of the bony part of nose, and hard palate defect all are signs that could be seen in congenital syphilis. Acquired syphilis. There are 3 types of syphilis which are I. Primary syphilis. An oral chancre appears 3 to 4 weeks after infection and may form on the lip, tip of the tongue or rarely other oral sites. It consists initially of a firm nodule about a centimeter across. The surface breaks down after a few days, leaving a rounded ulcer with raised indurated edges. This may resemble a carcinoma, particularly if on the lip. A chancre is typically painless but regional lymph nodes are enlarged, rubbery and separate. Serological reactions are negative at first, so the diagnosis depends on finding of Treponema pallidum by dark ground illumination of a smear from a chancre. The secondary stage develops 1 to 4 months after infection. It typically causes mild fever with malaise, headache, sore throat, and generalized lymphadenopathy, soon followed by a rash and stomatitis. Oral lesions mainly affect the tonsils, lateral borders of the tongue, and lips. They are usually flat ulcers covered by grayish membrane and may be irregularly linear, snails. Tract ulcers, or coalesce to form well-defined rounded area, mucus patches. Diagnosis is performed by serological reactions which are positive at this stage. Late-stage syphilis develops in many patients about 3 or more years after infection. The onset is insidious and during the latent period the patient may appear well. A characteristic lesion is the gamma, which clinically may affect the palate, tongue, and tonsils. The gamma can vary from 1 to several inches in diameter. It begins as a swelling, sometimes with a yellowish center, which undergoes necrosis, leaving a painless indolent deep ulcer. The ulcer is rounded, with soft, punched-out edges. The floor is depressed and pale in appearance. It eventually heals with severe scarring which may distort the soft palate or tongue, and the complication are perforate the hard palate or destroy the uvula. Management antibiotics, particularly penicillin, are the mainstay of treatment, but tetracycline and erythromycin are also effective. Treatment should be by a specialist and must be continued until nonspecific serological reactions are persistently negative.